It's my pleasure to speak about diabetic kidney disease. Always, diabetic kidney disease is a hot topic in nephrology because diabetes is the most common cause of chronic kidney disease and end-stage kidney disease worldwide. Today, I'm going to highlight the importance of aldosterone and its antagonists in the management of diabetic kidney disease. And I'm going to highlight the most important lessons from FIDELIO-DKD trial. Before I'm going to start, I have nothing to disclose, to declare. So there's no industrial affairs. And I discussed the issue of diabetic kidney disease early this month, but I didn't discuss the access of aldosterone and aldosterone antagonists. So I'd like to highlight this in this presentation. To start with, excessive aldosterone is associated with many problems and side effects. As you see clearly in this slide, if aldosterone is in excess, this will be associated with the stimulation of mineralocorticoid receptors with subsequent affection of the major organs. The most important for my mind is the cardiovascular and kidney, here fibrosis, heart failure, and chronic kidney disease. So both this is a very bad alliance. Kidney diabetes, kidney disease, and heart problems. Needless to say, if we use mineralocorticoid receptor antagonist, even from the rational point of view, this will ameliorate the effects of aldosterone on these systems. I like to share with you this very important critical review about the steroidal and the non-steroidal mineralocorticoid receptor antagonists in cardiorenal medicine. I like this article because it shows a lot of exciting pharmacological and other effects of using mineralocorticoid receptor antagonists. So we have two major types, steroidal and the non-steroidal mineralocorticoid receptor antagonists. What are the members of steroidal? We have, all of us are aware by spironolactone. It is the first generation mineralocorticoid receptor antagonist. Finerenone is the second generation, and the third and the current generation of mineralocorticoid receptor antagonists is expressed by Finerenone, and it is potent and selective. Here, if you look here, the spironolactone is unselective. Finerenone may be more selective than spironolactone, but here we have high selectivity for mineralocorticoid receptors. If you go to this table, you'll find the pharmacology. Here, spironolactone is distributed in kidney more than in the heart. This is from in vitro studies, in animal studies. Here, kidney from more than the heart. Finerenone is distributed in balanced way between kidney and the heart. Here, we have a long half-life for spironolactone, shorter half-life for Finerenone. Here, Finerenone, there is no active metabolites and short half-life. Regarding the cofactor recruitment, spironolactone and Finerenone are associated with inhibition of cofactor, and here Finerenone is more potent and effective in blocking mineralocorticoid receptor cofactor binding, and this is important as I'm going to show in the figure. The effect on mutated mineralocorticoid receptor, here there is a great difference. Both spironolactone and Finerenone are an agonist, while Finerenone is still antagonists. And the most important point is Finerenone is a strong anti-inflammatory and antifibrotic, and we need this access in management of kidney diseases. Let us see this slide because it is very important. It reflects how aldosterone works and how the aldosterone antagonist Finerenone behaves. If we look at the aldosterone, it goes to the cytoplasm to bind its receptor. This is unbound mineralocorticoid receptor, and then bound by aldosterone with the presence of cofactors and the recruitment of differential recruitment of mineralocorticoid cofactors. This will lead to the complex, and this complex will be translocated into the nucleus leading to gene expression of fibrosis and inflammation. That's it. So excess aldosterone is associated with increased fibrosis and inflammation. If we have Finerenone, Finerenone will block the complex formation with subsequent reduction of the genes expressing pro-inflammatory and fibrotic products, with the outcome of decreased inflammation and fibrosis due to mineralocorticoid receptor antagonist by Finerenone. I like this table very much because it shows in a simple way the difference between the three generations of mineralocorticoid receptor antagonists. We have the first spironolactone, second eplerenone, and third Finerenone, as I mentioned. And in this table, you can see the difference in selectivity for mineralocorticoid receptors. The highest selectivity is attained by Finerenone. Affinity for progesterone and androgen receptor, it is bad and associated with problems like gynecomastia. It is the highest in spironolactone, as you see in comparison to the third generation. The gonadal axis-related side effects, gynecomastia, impotence, breast tenderness, menstrual irregularities are also very high in spironolactone, but very low in the third generation Finerenone. Hyperkalemia, and it is very interesting for us because we are afraid of hyperkalemia. Here, the third generations are associated with less hyperkalemia in comparison to the first or third generation or second generation. This means that we have the current third generation with more potent, more selective regarding mineralocorticoid receptor antagonism with less side effects. Let us go to the FIDELIO-Diabetic Kidney Disease Trial. And this trial was announced in details in the Renal Week of the American Society of Nephrology in 23rd of October by Professor Agrawal. And this is the title of the topic he presented: Effect of Finerenone on chronic kidney disease outcome in type 2 diabetes. The article is already published in the New England Journal of Medicine in the same day. It is 23rd of October. And under the title, Effect of Finerenone on chronic kidney disease outcomes in type 2 diabetes. Always we are interested in any trial putting kidney in the outcome. So it is double blind. What's meant by double blind, it is the strongest design of interventional studies. And it is devoid of both selection and the performance bias. What are the number of patients? Large number of patients, type 2 diabetes with kidney disease. 5,700 patients were included in the randomization, and the patients were allocated equally into Finerenone arm, 2,800, and the placebo, 2,800. So this is a very interesting and very important study to address the question, what is the effect of Finerenone as the third generation mineralocorticoid receptor antagonist on the outcome of kidney disease in diabetic patients. What is the dose and how they manipulate the dose? If estimated GFR of 25 to less than 60 milliliter per minute at the screening visit, the initial dose is 10 milligram. If it is 60 or above, the initial dose is 20 milligram once daily. An increase in the dose from 10 to 20 once daily was encouraged after a month to be sure that there is no hyperkalemia, provided that serum potassium is less than 4.8 millimole per liter or less. A decrease in the dose from 20 to 10 was allowed at any time after the initiation of Finerenone or placebo. We have placebo. There is a shame change in placebo like Finerenone because the doctors and physicians don't know which is placebo and which is Finerenone. After randomization, trial visits were conducted at the first month, fourth month, and then every 4 months until trial completion. Finerenone or placebo was withheld if potassium concentration exceeded 5.5 millimole per liter and restarted when potassium levels fell to 5 or less. So potassium was monitored and the manipulation of drugs were thoroughly followed up. This is the demographic criteria of the patient, and this is what I recommend for any randomized clinical trial. All of us should look at demographics criteria very well, because one of the problems of randomization, we shouldn't generalize the results. We should stick to the demographics. If you look here, for example, black patients were expressed in less than 5% in both arms. I think this is a limitation of generalization of the result of this study. Regarding the kidney, this is the values of estimated GFR. The mean estimated GFR in both arms was around 44 milliliter per minute. And this is the distribution above 60, 45 to 60, 25 to 45, less than 25. You can find here the majority of patients are in this category. More than 52% of the patients were in the between 25 to 45 milliliter per minute estimated GFR. What about albuminuria? Albumin creatinine ratio measured milligram albumin per gram creatinine. This is the median values of albuminuria in both arms, and this is the distribution A1, A2, and A3. More than 85%, 87% of patients were in the zone of A3, albuminuria grade 3. Serum potassium was less than 4.5. So this is the demographic at the initiation. One of the important messages from the demographics is Finerenone, which is mineralocorticoid receptor antagonist, was added on top of RAS blockade. So nearly all patients were treated with either ACE inhibitors, 33% here, 34% in placebo, or angiotensin receptor blockers, 66, 65. Only 14 patients were not treated with ACE inhibitor or angiotensin receptor blockers. This is to put in mind. So Finerenone was added because this is a long-standing diabetes. You'll find insulin was here was present treatment, and GLP-1 receptor agonist or SGLT2 inhibitors. This is the distribution and the percentage of the drugs used for treating diabetes. This is the main result. Primary composite outcome. The hazard risk is 0.82. This means we have 18% reduction of renal outcome, and the p-value is highly significant. I'm going to explain this in the hazard ratio table, and this is the sustained decrease of GFR less than 40% in the estimated GFR from baseline. Again, significantly less in Finerenone in comparison to placebo. 19% reduction. So this is a good news for the kidney, and this is for kidney failure, although it is not significant here, but the hazards for secondary composite endpoints were significant. It is 0.76. What are the secondary composite outcome in this study? A sustained decrease of at least 57% in the estimated GFR from baseline, equivalent to doubling of serum creatinine level, maintained for at least 4 weeks, or death from renal causes. Let us go to the hazard ratio, because I like to see everything in details. So primary composite outcome here, and this is Finerenone, 17%, 21% in placebo. This means we have 4% reduction, and this is the significant reduction favoring in the favor of the use of Finerenone for reducing the primary composite renal outcome. And these are for kidney failure, end-stage kidney disease and need of dialysis. This is insignificant. Sustained decrease of more or equal 40% in estimated GFR from the baseline was significantly reduced in the Finerenone treatment group. So this means that adding Finerenone was associated with reduction of progression of CKD. Again, the secondary composite kidney outcome, sustained decrease more than 57% in estimated GFR from the baseline. Both of them were significantly lower than one, far from one, favoring the use of Finerenone for the kidney outcome. And as I mentioned in the beginning, the study was announced in the SN week within the high impact clinical trial sessions. And this is the main message from the presentation. Overall, summary and the conclusion of this trial in patients with CKD and type 2 diabetes treated with optimized RAS therapy, ACE inhibitor or ARBs, Finerenone was well tolerated and significantly reduced. I'm going to highlight the safety in a minute. The risk of CKD progression is reduced by 18%. The risk of cardiovascular morbidity and mortality is reduced by 14%. One of the most important questions to be asked, what are the number need to treat, because it is important in randomized clinical trial. If the number need to treat is less than 100, it is a good result. So primary kidney endpoints was the number need to treat was 29. It is good. Secondary cardiovascular endpoints is 42. So there is a modest effects on blood pressure. I would like to say here, Finerenone is not the blood pressure targeting drug. It is inflammation and fibrosis targeting drug rather than hypertension, to put it in mind. Consistent effects on components of primary endpoints according to different categories, consistent effects across subgroups, including estimated GFR and urine albumin creatinine. And this is the behavior of urine albumin. You can find significant reduction of urine albumin creatinine ratio from the early beginning, as you see in this follow-up for 36 months. And this is the change of potassium, the difference between placebo and Finerenone. There is some increase, but little. It is not a strong rise of potassium. Adverse effects and safety profile of Finerenone in comparison to placebo. It seems that it is of high tolerability, but let us focus on potassium. So this is hyperkalemia, investigator reported hyperkalemia, 18% in Finerenone, 9% in placebo. Hyperkalemia related to trial regimen, 11.8%, 4.8% in placebo. Serious hyperkalemia, 1.6%. So this is a good. Serious hyperkalemia is 1.6% in comparison to 0.4% in placebo. Hospitalization to hyperkalemia, 1.4% in Finerenone, only 0.3% in placebo. Permanent discontinuation of due to hyperkalemia of Finerenone due to hyperkalemia, 2.3%, 2.3% in Finerenone, 0.9% in placebo. Yes, hyperkalemia is important problem, but it is not like the previous trials using spironolactone, and this is assuring data so long as we are following our patient. This is one of the comparison presented by Professor Agrawal. FIDELIO-diabetic kidney disease in comparison to AMBER. In AMBER, here the betromere was used with spironolactone to reduce the incidence of hyperkalemia. If you look here, without the betromere, hyperkalemia is 23%. And here the significant hyperkalemia was 2.3%. It seems that there is a contrast toward the safety of Finerenone in this issue. This is why the Professor Agrawal stated that although hyperkalemia increased, it was manageable. Only 2.3% of patients discontinued Finerenone versus 0.9% in placebo. What are the major limitations of this randomized controlled trial? I like always to consider limitation. Most patients had advanced chronic kidney disease. The trial excluded patients with non-albuminuric chronic kidney disease and chronic kidney disease not due to type 2 diabetes. What is the value of this limitation? We shouldn't generalize the results of FIDELIO-diabetic kidney disease to non-diabetic CKD or non-albuminuric chronic kidney disease patients. Only 4.7% of participating patients identified themselves as Black, as I mentioned in the demographics. So this is one of the limitations that restrict the generalizability of the findings of this clinical trial. Further insights into the cardio-renal efficacy and safety of Finerenone in patients with type 2 diabetes and the less advanced CKD will be provided by the ongoing Finerenone in reducing cardiovascular mortality and morbidity in diabetic kidney disease, Figaro diabetic kidney disease trial. So are waiting, always we are waiting ongoing trials and results, because the future may tell us, may confirm or may differ the conclusions that we have. Up to this moment, I agree with the editorial title of the article that Finerenone is considered a new magic bullet against CKD progression by halting relative hyperaldosteronism in chronic kidney disease. I should stop here. Thank you very much for your attention, and I'll be very happy for any comments you write on the YouTube video. I'm going to release it in minutes. Thank you and goodbye.